Hi, my name is Brian Apavu. I am a neurologist and epileptologist with an interest in philosophy of the mind and living the examined life. Today, I want to dive into the topic of juvenile myoclonic epilepsy, an epilepsy condition that I commonly see. First, I want to start with a disclaimer. This video is medical education, not medical advice. If you need medical advice, please talk to your clinician directly regarding your specific situation. So, what is juvenile myoclonic epilepsy? Juvenile myoclonic epilepsy is a common genetic generalized epilepsy syndrome, typically presenting around the adolescent period with with a triad or three types of common clinical manifestations. The most common is myoclonic jerks. This is mandatory to the diagnosis. These jerks are the sort where there's an axial sort of brief, sudden jerk of the shoulders, the trunk, the limbs, the lower extremities, and so forth. It's just kind of a jerk that is sudden, irregular. It can be irregular or a little regular, and happens at certain periods of time, which I'll discuss. So, juvenile myoclonic epilepsy will often have the myoclonic jerks. It can also manifest with generalized tonic-clonic seizures, what we classically called grand mal seizures in the past, and sometimes absence seizures, seizures where you stare off. The onset of juvenile myoclonic epilepsy is usually around the ages of 10 to 25 years of age, with a peak in the mid teens. And it is fairly common in the grand scheme of epilepsy syndromes. It accounts for 5 to 10% of all epilepsy cases and has a slight female predominance. Now, like I mentioned, the clinical manifestation is commonly the bilateral myoclonic jerks, both sides, most often involving the arms, most occurring shortly after awakening, and often is precipitated by sleep deprivation, stress, or alcohol. A common manifestation that I'll hear from families is or patients is that they just feel a brief jerk of their extremities. It kind of gets worse in the morning, and it's something where if they're writing or typing, they just suddenly lose control of the ability to do that. If they are have a cup of coffee or some sort of they may drop that cup of coffee just because it's of such an involuntary jerk. And I mentioned it can be precipitated by sleep deprivation, stress, or alcohol. So we commonly counsel patients to find ways of getting enough sleep, lowering their stress level, and trying to reduce the amount of alcohol that they consume because this can make those jerks worse. Generally, tonic-clonic seizures occur, and less frequently, those absence seizures or staring spells that also can occur. The EEG of a patient with juvenile myoclonic epilepsy often has something what we call a generalized polyspike and wave discharges. The jerks can often manifest with these polyspikes. If you're doing a long continuous EEG recording, you can see that they have a correlate to each other. And the other thing that's fairly common is this type of epilepsy, juvenile myoclonic epilepsy, has a certain photosensitivity to it. So when we shine flashing lights, we can elicit the polyspike and wave discharge is something we call a photoparoxysmal response. And these are the type of epilepsies, one of the few type of epilepsy where we do worry about flashing or shining lights actually being something that could potentially provoke seizures for getting worse. Now, juvenile myoclonic epilepsy, this is important. It's generally not considered a severe epilepsy in terms of neurologic decline, but it is often a lifelong disorder for most patients with a tendency to relapse if seizure medications are discontinued. There are a lot of high functioning individuals in society and the community that have juvenile myoclonic epilepsy, including doctors, politicians, and people with with a high degree of education and that do highly competent work. So if you end up with a diagnosis of juvenile myoclonic epilepsy, or one of your family members do, it doesn't mean that you can't have a great quality of life and can't achieve great potential. And certainly I've had a number of patients who do achieve those great things. So it's not something to find yourself necessarily limited in your achievement, but it's something you have to know about, and something, and you have to find a way of balancing the use of medication and your seizure control, and just to live the best life you can. So, about two-thirds of patients with juvenile myoclonic epilepsy will achieve good seizure control with appropriate therapy, but up to one-third of patients can be what we call drug resistant. And that is when they continue to have seizures despite at least two anti seizure medications being used at sufficient therapeutic dosages. Cognitive and executive dysfunction can be observed in patients when they're studied at a high level, particularly involving the frontal lobes, and this can impact interpersonal relationships and quality of life, even in the absence of intellectual disability. Long-term cognitive and psychosocial outcomes in juvenile myoclonic epilepsy can be characterized and have been studied to be associated in neuropsychological testing to be associated with deficits in executive function, attention, memory recognition, and there can be a high prevalence of psychiatric comorbidities at all as well. So we want to be able to recognize these and be able to help patients in terms of their overall quality of life in light of these things. There are studies that show there are studies that show this decline in executive function and sort of frontal lobe function, things with attention and executive function, and memory. And there also are functional neuroimaging studies as well as diffusion tractography type of studies that look at connectivity in the brain and show reduced connectivity out of white matter within the frontal lobe. So this is just objective finding that we see in patients with juvenile myoclonic epilepsy. As I mentioned, juvenile myoclonic epilepsy typically does not self-resolve. Most patients do require lifelong treatment, and the relapse rates are about 70 to 80% after medication withdrawal in patients with juvenile myoclonic epilepsy. And this has been supported by multiple cohort studies as well as meta-analyses. This is one meta-analysis that examined 43 studies that found that in juvenile myoclonic epilepsy, seizure recurrence occurred in about 78% of patients with a 95% confidence interval of about 52 to 94%. And this is specific to individuals with juvenile myoclonic epilepsy who attempted anti-seizure medication withdrawal after a longer period of seizure freedom. Now, when we look at clinical studies that look at what medications are out there and what could be the drug of choice, it appears based on the evidence that valproic acid, or what we often refer to as Depakote, is the most effective and widely recommended first-line agent for juvenile myoclonic epilepsy, with studies showing high rates of seizure freedom of up to 85 to 92%. Retrospective cohort studies have demonstrated that valproic acid achieves the highest rates of seizure remission in juvenile myoclonic epilepsy as compared to other anti-seizure medications. In a multi-center study of 257 patients, valproic acid was associated with a higher likelihood of achieving seizure control than levetiracetam, what we call Keppra, despite Keppra having a better side effect profile. And we'll talk about the side effects of valproic acid in a little bit. A long-term audit of 186 patients found that valproic acid monotherapy, or just the use of valproic acid, resulted in the remission of seizures in 52% of cases, outperforming another medication, lamotrigine, which had remission rates of 32%. Lamotrigine is also called Lamictal, and then levetiracetam or Keppra, which was at 50, which is around 50%. And overall, valproic acid was the most effective agent for seizure freedom in juvenile myoclonic epilepsy. Now, like I mentioned, valproic acid does have significant side effects, and well-known side effects such as weight gain, thrombocytopenia, alopecia or hair loss, and it's contraindicated in women of childbearing potential because it can have a high risk of teratogenicity for the fetus. Alternatives to valproic acid, particularly in childbearing women, include things like lamotrigine and levetiracetam, with the drug choice tailored to the seizure type, patient characteristics, and how well they respond to that seizure medication. We worry that some of the specific sodium channel inhibitors, such as oxcarbazepine, carbamazepine, and phenytoin, might worsen seizures for patients with a juvenile myoclonic epilepsy, and we generally say that they should be avoided in this condition. In women of childbearing potential, levetiracetam and lamotrigine, like I mentioned, can be preferred, and levetiracetam has shown some superior efficacy in some studies to lamotrigine in direct comparison, especially after valproic acid withdrawal. Combination therapy with valproic acid and lamotrigine is highly effective in drug-resistant cases, with some studies showing that it has the highest rates of seizure freedom among those patients with juvenile myoclonic epilepsy that need to undergo dual therapy. Now, valproic acid and lamotrigine can interact with each other, so it's really important that you work with the doctor to be able to assess the drug levels of these. You want to make sure that medications don't, the drug levels don't rise. Either drug level doesn't rise to the point that you're going to experience significant side effects. With lamotrigine, you're worried about the Steven Johnson rash, which I'll talk about in another video, which is a dangerous rash they develop in your skin. And with valproic acid, like I mentioned, the teratogenicity risk, the weight gain risk, the thrombocytopenia, or an increased risk of bleeding. So you want to be, these medications can work really well together and achieve high seizure freedom rates, but you do want to be cautious not to end up having too high of drug levels because they can interact with each other. Alternative therapies that have been studied and described for juvenile myoclonic epilepsy include topiramate or Topamax, zonisamide or zonicide, and perampanel or Fycompa. But however, the evidence for efficacy of these type of anti-seizure medications is relatively limited and of low certainty, not necessarily because they're necessarily poor choices, just we don't have great studies on them sometimes. And then we use benzodiazepines or barbiturates for specific settings such as rescue therapies. Although you can use a medication like clobazam or Onfi, sometimes in patients with juvenile myoclonic epilepsy with some good effect. If patients fail 2 or more anti-seizure medications, the odds that a third medication is going to do the trick and do wonders is relatively low. This is where we'll start to consider other types of therapies, which I'll talk about in other videos, such as trying ketogenic diet, trying some neuromodulation with the use of, there's vagal nerve stimulation, responsive neurostimulation, or deep brain stimulation. These are potential options in a drug-resistant generalized epilepsy conditions. So we start to think about those in patients who fail 2 or more seizure medications, simply because the data suggests that the third medication there's a very low likelihood for it to do the trick. Currently, there are no therapies that are proven to be disease modifying for juvenile myoclonic epilepsy. What we think about with juvenile myoclonic epilepsy, as well as a lot of the epilepsies that we have, is that anti-seizure medications are pretty good at reducing the amount of seizures you have. Lowering the amount of seizures that you have when you have epilepsy can help with your quality of life, because you're not having seizures that can limit your ability to go by your day-to-day function and do the things that you want to do. But these anti-seizure medications haven't been shown to be disease modifying, meaning they reverse course of the disease, they stop the disease from progressing, they improve other aspects of the epilepsy. So we use this anti-seizure medications or other anti-seizure treatments to stop or lower the risk of seizures, but not necessarily to prevent juvenile myoclonic epilepsy or resolve the epilepsy. Like I mentioned, all these medications, because they're focused on reducing the amount of seizures you have, they are what we call symptomatic treatments. And there is ongoing need for research into disease-modifying therapies and novel agents for juvenile myoclonic epilepsy, as well as many of the epilepsy syndromes we have. Lifestyle interventions can be helpful. Like I mentioned, sleep deprivation, alcohol, and stress can worsen the seizures in patients with juvenile myoclonic epilepsy. So the more that we can get high quality sleep, reduce the amount of stress we're having, and then also reduce the amount of alcohol we're having, it's going to help us get our seizure threshold lower and give us the higher likelihood that we can achieve good seizure remission with without having to go to toxic levels of anti-seizure medication. So this is sort of what we want to go for. And we also want to bear in mind, we want to bear in mind the evidence in neuropsychological studies that there's a high risk for issues related to executive function, attention, and some psychiatric symptoms such as depression and anxiety that's associated with juvenile myoclonic epilepsy. It is a network phenomena. So we want to bear this in mind in order to help patients. There is a lack of head-to-head randomized clinical trials and sufficient data on long-term disease modification in juvenile myoclonic epilepsy, and it's needed. Common misconceptions with juvenile myoclonic epilepsy include under-recognition of the disease, misdiagnosis as potentially a focal epilepsy, and the belief that juvenile myoclonic epilepsy is likely going to be self-limited. In most cases, it is not. The name juvenile myoclonic epilepsy may contribute to reification as it implies a discrete static entity, where a juvenile myoclonic epilepsy is part of a spectrum of the idiopathic generalized epilepsies that can include juvenile absence epilepsy and other types of idiopathic generalized epilepsy that carry overlapping features and genetic susceptibility. There isn't a single gene that we say, oh yeah, that's juvenile myoclonic epilepsy. These things tend to overlap, and it's a syndrome that we've classified based on common shared characteristics of patients that have this phenomena, both with their clinical manifestations as well as their EEG. So I hope you enjoyed this video and found it of value. If you did, please like this video and subscribe to the channel for more additional content. I hope you have a wonderful day.